correcting this tear trough areas or infraorbital aging signs, you might want to do a rich rod injection in the superficial layer, also a little bit of toxin to release this tear trough muscle that would help release these aging signs. And nasolabial fold, why are they get more prominent? Because all those lip elevators, they attach to the dermal layer. And most of the facial muscles, they consist of two layers, superficial and deep layers. And for the zygomedicus major muscle, they originate from the periosteal layer in one bulk of muscle fibers. And then when they go into or perioral region, they divide into two. Superficial layers, they attach to the nasolabial fold, and deep layer, they merge and intermingle with the orbicularis oculi muscle. Okay, when you see it with the micro CT, it's the same, right? So marionette line, the DAO muscle fiber, they turns to the collagenous fiber and attach to the marionette line. Okay, and when you go to the medial or perioral region, it gets much denser. The retinacular cutis is much denser in the medial area to the marionette line. And when you go laterally, the retinacular cutis is much more loose. And that is why I think Dr. Chu did a Ridgeron injection to strengthen the lateral part of the marionette line to relieve these jaw fats, okay, the appearance of the jaw fats. So marionette line, they get much, they are the, they get prominent cause the fat losses, as well as we have much more tight retinacular cutis in the medial parts of the marionette line. So this is the summary of how we distribution of the fat in the facial layers. So purple shaded area is where we got more of a fat accumulation within the compartment, and the orange shaded area we might use fillers or polynucleotide to volumizing purposes. Okay. Ligaments, they do get aged. The laxity we see in the histological section, and also we can definitely see them getting laxity in the ultrasonography observations too. So true ligament, false ligament, we call true ligament from periosteal layer to the dermal layer, and false ligament somewhere in between the facial layer to the dermal layer. Okay. So orbicularis retaining ligaments, they are the true ligaments. They come from the periosteal layer, penetrating to the orbicularis oculi muscle, then to the dermal layer. So this ligament tissue is holding this infraorbital fat pad not to migrate to perioral region or somewhere else as we get old. So tightening, like a polynucleotide seems to have strengthened the ligament tissue. So another way to correct this sagging is to do a strengthening in a particular facial ligament regions with polynucleotides, okay, DOTPN. So when we see our facial structures with the ultrasound, when we go with the low hertz, we go deeper. And when we go with the high hertz, we can see the superficial layers. And mostly, when we look at the facial layers, we don't go too low. So 15 hertz to 20 hertz is the most of the ultrasonographers use to see the facial layers. And to observe the dermal layer, we go higher with the 22 hertz. And when we see a DOTPN injected in the intradermal layer, we see that spread and go to the subdermal layer. So they do spread, right? So, and also we can see it in the ultrasonography, and this one has been injected with the O2 mated injector. So what I want to say is that why do we manage the papule, and why do we ask our patient to bear with the pain? Intradermal injection is painful because there are lots of pain sensors, free nerve endings, and they are the reason why we feel the pain is they have several factors: pH, viscosity, needle size, maybe injection speed. Okay. So how can we reduce the pain while doing an intradermal injection? We can use microneedle, okay? Less the damage to the nerves, and slow injection. It will last with the tissues around the injection, bolus injection, right? And also we can use the gate control theory, right? Ice pack, chillers, vibrations, and also we can use a lidocaine injection, right? It can be a nerve block, or it can be mixed with the polynucleotides, okay? There are two ways. And I'm gonna talk about nerve blocks. Nerve blocks, it's kinda hard to do the lateral face nerve blocks, because you gotta approach from the intraorally, okay? From the outside, it's not beneficial, because like auriculotemporal nerve, they go along with the superficial temporal artery. So there are possibility of damaging these structures. And also the buccal nerves, they are hidden in the very deep part of the lateral face. So if you are not used to it, I don't recommend do a lateral face nerve block. But in the medial face nerve block, I would suggest a lot. And it reduces pain so much. For example, if you do infraorbital nerve block, it's just one shot, okay? One shot at each side, and it will cover the anterior cheek, okay? So with the nerve block, you can just manage 2 cc of Reach-Run to do anterior cheek area, okay? And also you can do the forehead. Forehead, you are targeting in between the corrugated supercilii. So you palpate the midline of the eyebrow, and you see the nasal bone. You palpate the nasal bone, and this is the origin and the insertion point of the corrugated supercilii. And you gotta know this infraorbital and supraorbital and supratrochlear, they come up attached to the periosteal. So what you have to do is to do a bone touch and do a lidocaine injection in between the corrugated supercilii muscle. Or infraorbital nerve block, they can be done in most of the people. You palpate lateral canthus, and you see the lateral part of the nasal ala, and you make it like divide into 3 even pieces, and that's the point where you do lidocaine injection. How about mental nerve? Mental nerve, you gotta see and check the first premolar, and do an injection at the point in the mid of the mandibular bone. Okay. So left side and right side, which part should we start first doing a skin booster injection? If you're not doing any nerve blocks, which is more painful, left or right? Left side is more painful. It's not only limited to the facial region, but body parts too. Okay. So when you put gradually increase the pain threshold, as it's more painful. Okay. The previous literature says. So what you want to do is do a painful side first. Put the pain threshold in the upper limit. Then you go with the right side. Okay, that's the how you can reduce the pain. And also intradermal and subdermal, which is more painful. So people who are not tolerable with the pain sensation, you might want to do subdermal injection of polynucleotides. Okay, because they spread. Okay. And the pain, we are measuring and doing researches on the pain. The FAST score is 3 point lower in subdermal injections. And if you use HB, which contains a lidocaine. You might want to do sparsely injection, then you fill up in between. Okay, it will make patient much less painful in the second trial when you fill up. Okay, because the lidocaine spreads. Okay, and when you do a HB injection, you might want to do a little bit deeper, subdermal injection. And after that, the second trial, when you fill up, you might want to go superficial. The lidocaine is more effective when it's in the subdermal. So when you do intradermal injection, you got to avoid some of the superficial veins, and that is intercanthal vein and some of perforating arteries in the midface, in the cheek, and the of course sentinel veins. Okay. So these perforating arteries are located in the mid anterior cheek, and they come from the transverse facial artery mostly, and zygomedical orbital artery too. So these are the blood bleeding that can be happen, and facial artery very tortuous. Okay, they come into superficial in the lateral to the modulus. Okay, when you do a puncture site here, you might want to do more medially than the modulus, because you might puncture this facial artery. And also, they come up superficially in the inferior part of the nasal area. So that's the facial artery where they go superficially. And as I told you, there are some of the superficial veins that you might damage, and they are intercanthal veins, of course, lateral nasal vein, supratrochlear, they are pretty superficial than other veins, and of course sentinel veins, right? Intercanthal veins, and sentinel veins, they come from the middle temporal vein, and they perforate to orbicularis oculi muscle, then spread into lateral temporal region. So if you are not able to see, this is all intercanthal veins. They are very subdermally located. Okay, so middle temporal vein, they come up and become a sentinel vein, but the people, they are not able to see a sentinel vein as the patients. Okay, to close their eyes for me, and it will engorge. It will definitely get larger. So these are the sentinel veins. Some of doctors, they do care about it, but yeah, it's just definite. Okay, you don't want to hit that structures and make a bruise. Okay, and when we do combination therapy with polynucleotide, not only polynucleotide, about the skin boosters. Skin boosters, you got to know positive flow rate, pressure, the manipulator's thumb pressure, radius of the syringe, fluid viscosity, length of tubing, all matters. So harder the viscosity that you are trying to deliver, it gets harder to control and harder for the manipulators to make a pressure on it. Okay, lower viscosity is much easier for the skin booster injection. How about needle length? When the needle length is too long, it gets harder to do our injection delivery. So shorter needle, like there are like 2 millimeters needle, nowadays 4 millimeters needle. So you might want to use shorter needle delivering skin boosters, and syringe diameters. You don't want to use the pressure gets exponentially harder to get that injected. So you might want to use 1 cc syringe. In maximum, you might use a 2 cc syringe. Okay. So HB, they come with 1 cc syringe. Vigilant original, they come with the 2 cc syringe. I think that's the ideal syringe that we can use for the skin booster injection. And there are a few micro needles, lengths of 2 millimeters, 4 millimeters. So I do nerve block for infraorbital area, mental nerve, supraorbital area. And when you do this, as much. They don't feel the pain actually. They don't feel the pain. Okay. And I do combine a PRP or toxin in my clinic with the rich run. And we can definitely use auto-injectors. They will make it evenly located in a certain layer. If you're not expert in using this skin boosters. So nowadays we have like laser-driven or like air-driven, needleless injectors, and also you can use that with the rich run. There are many ways to deliver skin boosters nowadays, laser-based. And when you want to control the depth, you can stack it. And also, this is how I treat my patients in the clinic for the horizontal necklines. So they do a subcision with the air, then puts in a polynucleotide in it. Okay. So there are so many manipulations that you can do with the rich run. So I think it will have a lot of potential in the future, and we will get more evidences in track of not only for the skin boosters, but as a filler-wise. So this is a special issue that I'm running right now. So polymers for aesthetic purposes. It's a pretty decent paper. It has an impact factor of 4.7. If you have any ideas, any interest in publishing paper on this issue, please let me know. Okay. Thank you.